Good morning, everyone. Check, check. Hello, good morning, everyone. I'm Julian Lucas, and I'm excited to be your host for the Health 2.0 Conference Summer Edition 2023. Welcome to the vibrant city of Las Vegas and the Grand Caesars Forum. For the next 3 days, we have a lineup of panel discussions, fireside chats, and an exclusive showstopper session to enhance our understanding of advancements in healthcare, opportunities, and challenges for how we can all ensure a better and healthier future for all. Before we begin, I would like to express my deepest gratitude to our esteemed partners. A huge thank you to our gold sponsor, Nemours Children's Health, and our silver sponsor, BrainTap Inc., for making this event possible. And a quick reminder, don't forget to share your conference memories on your social media using the hashtag Health2Conf. That's hashtag Health2, the number 2, Conf, C-O-N-F. We would love to be a part of your social media stories. Now that we're all here together, let's begin the day with our enlightening session on the revolution we need, driving structural changes for health equity. In this session, panelists will explore the crucial structural changes needed to battle healthcare disparities, diving into systemic issues like socioeconomic status, race, and location. I'm ready to delve into our journey and understand how to construct a more inclusive, equitable global healthcare system. How are we feeling today? Oh, come on, let's get a little more energy. There we go. Thank you. So, ladies and gentlemen, let me introduce to you our panel of leading experts. Please put your hands together for our moderator, Kris Narayan, Chairman and CEO of MediKarma Inc., and our panelists, Laura Evans, owner, Psychedelic-Assisted therapist, supervisor, trainer, and consultant at Laura Evans Counseling, PLCC. Andrei, Naeymi-Rad, Vice President of Corporate Strategy at Intelligent Medical Objects. Dr. Sachi Ananda, Program Director of Shatterproof at FHE Health. And Rick Johnson, Vice President of CMI Media Group. You're welcome to come to the stage.
Good morning. Can you hear me okay? So you know it's there's only one type of thing. Can you hear me now? There's only one type of thing. But you're going to meet other families very soon. She happens to be a virtual AI bot. So I'm going to be talking to her, listen to the conversation. But before I get started, how many of you are from the clinical side of health? Thank you very much. How many of you are on the technology side of health? Good to know, good turn. Very good. So the topic of the discussion today is health equity. When we look at health equity, we can see three issues. One is access to healthcare. How easy is healthcare available? That would actually include the lack of doctors in certain regions. Like when I go to Amazon, I can't see a doctor in the region. There's no visual. So access to healthcare includes ability to get health insurance. Perfect. Fair enough? Okay. So access to healthcare, doctors available for you, you having access to insurance, your ability to offer insurance, so access to healthcare. The second thing interestingly that I know is the quality of care. I keep hearing from some of my partners how doctors are burning out, how they're taking more time off because the stress is very high, how the commercialization of health has resulted in profit criteria that's driving doctors to spend more on their time on this subject. The second thing we're finding out is the doctor advisor, just to name a one thing, told me that yes, 20 patients a day. And very often they have to be while looking at ethics also. So the attention they have, the timing, quality of service. So these are the issues that we are facing. Each of the finance members here is going to give them. And I'm going to give you a little what they do to certain value. How we're going to focus. I'm moderating the demand, reducing the demand, and increasing the demand. So with that, let me pass on to Laura. Each one of you can introduce yourself, your view on health equity, and let's go.
My name is Laura Evans. I'm a licensed marriage and family therapist supervisor living in Austin, Texas. I currently supervise graduate students and marriage and family therapist associates who are interested in specializing in psychedelic-assisted therapies. I specialize in ketamine-assisted therapy. I also am the lead therapist at Illuma, which is a leading ketamine infusion clinic in Austin. I serve as the past president of the Austin Association for Marriage and Family Therapy, and I aim to create a practice where not only clients are able to access more affordable psychedelic-assisted therapies, but the people that I'm training and supervising can also access more affordable training and supervision, because psychedelic-assisted therapy is very expensive to access as a client, and it's very expensive to access training as a clinician.
Good morning, everyone. My name is Dr. Sachi Ananda, and I'm a program director for Shatterproof at FHE Health, which is an inpatient mental health and substance use facility down in Florida. Has anybody gone? We've got some others going that far, yeah. So the program that I oversee is specifically for first responders. And I'm very excited to see that there's some vendors and other organizations and agencies here who are helping first responders get help. What I find when we talk about health equity with first responders is just simply having the people who serve our country and our communities get access to healthcare. So, for example, in Florida, at our facility, we're insurance-based. And what we find actually is that the police in our state may not even be able to attend and participate in our program and get treated for post-traumatic stress disorder because their healthcare isn't providing those type of reimbursements to enter into private facilities. So I like to kind of have us think about how do we help our first responders get access to healthcare, and not only that, but break through the stigma of a first responder having a mental health disorder. So I'm excited to have us discuss those type of questions.
Thank you.
And hi, everybody. It's way loud. Andrei Naeymi-Rad. That was really small. VP Corporate Strategy. I take the position of being in healthcare informatics and data strategies for healthcare software organizations and enterprise data governance strategies for large organizations. Been in the market for 20 years, so have seen everything from mom and pop doc shops in the middle of nowhere, Montana, to large academic medical centers and health systems, working with insurance organizations as well as providers and pharma and life science and CRO research operations. So as you think of my position in this kind of area, I'd be more focusing on data strategies, what we're seeing in the industry, social inequity within those data operations, and how that can affect direct care.
Hi, good morning, everyone. I'm Rick Johnson. I am the Vice President of Audience Intelligence for CMI Media Group. And CMI is a media agency that is focused exclusively on healthcare and is part of the WPP family of companies. So roughly 1 out of every 5 ads in the world comes out of a WPP company. So excited to be here. My position when it comes to, well, first I should let you know that I am not speaking on behalf of CMI. I'm speaking on behalf of myself today. But when part of my job is to look at different communities and see if they are being served in different ways than other communities, and is that lead to a positive outcome or a negative outcome. So I carry that over when thinking about what does health inequity mean. Are there communities that are being underserved or served in a different way, perhaps without the same level of resources as other communities might be receiving? And again, why is that the case? So again, thankful to be here and excited to be a part of this panel.
So Rick, I can start with you. What do you think of health equity in this country and status? What are your possible solutions to reduce out of business?
Sure. So I guess I would start by trying to illuminate some of those differences that I mentioned exist. As an example, if you look at people that have some sort of medical condition, roughly 65% of them in the United States take some sort of medication. But when you break that down by race and ethnicity, you find out that 67% of whites are receiving medication, 66% of blacks receive medication, but only 61% of Asian Americans and 56% of Latinos are receiving medication. Then when you dig in a little bit further and you look at, of those different communities, how many have had their medications adjusted within the last few years, you find out that 25% of whites have had their medications adjusted in the last few years, but only 17% of blacks and roughly 15% of Asians and Latinos have had their medications adjusted. So it makes you wonder, like, why? What is it about those different communities? Is it education? Is it the care that they're receiving in their physicians? Is it something cultural? But something's leading to those differences. And it shows up also when, we had touched on social determinants of health, which is a little bit challenging because there's no one set definition of those variables. But we use 10 different variables to look at social determinants of health. And when we compare, when we do a regression analysis of those 10 factors as how they influence overall health, we find that, again, there are differences between caregivers and those who are not caregivers. We also see differences in the LGBTQ plus community versus the heterosexual community. And then, again, communities of color versus white communities. So those adverse impacts, are important because as we're trying to figure out how to help people and how to get them to their best state of health, there are other social determinants that are negatively impacting that effort. And we need to be aware of those and be able to factor those in when coming up with care plans. And so the last thing I would say is that it's not just the hard statistics where we see this. When you do social listening and you look across different communities, when we're examining the neurodivergent community, we see that there was a clear pattern where blacks were often saying they couldn't get that diagnosis at first and had to fight for it and go to multiple doctors because all too often their children were just being labeled as sort of like troublemakers or not willing to listen or, poor students, whereas others that ended up getting the same diagnosis didn't have those hurdles that they had to overcome. So in terms of what's the solution, that's tough. I'm not sure that I have the answer. Otherwise, I'm going to have to be sitting up here right now. But there's a few things. I mean, certainly education and making sure that we work across the entire sort of healthcare ecosystem to make sure people are aware of the challenge and that we're coming up with solutions that are community-based and make sense for each piece of the ecosystem, but that also connect to one another.
Thank you. where do you see it proceed?
Sure, and I think very similar to my colleague here on the panelist group, what we're seeing in the data ecosystem as you're trying to understand patient populations as a whole, data becomes lost in translation. When you look at clinical data, claims information, you're noticing an overlapping of common definitions of information. So whether your user persona that's understanding your patient population at hand is a data governor, data steward, or actually a clinical informaticist, gaining insights into those patient lives becomes ever increasingly complicated. And as you think about regulatory pressures that are trying to affect change in support of social need, social determinants is a great process in moving towards a much more holistic understanding of your patient population. The problem that's actually happening that we're seeing in the industry with social determinants is that the coding guidelines that reflect patient populations is a ever-moving, changing operation. So today, what might have been coded as a need-based patient profile might be something completely different 6 months from now, 10 months from now. For those of you that are in the trenches dealing with clinical coding for COVID, you guys have seen this a little bit more tangibly compared to the social determinant side. But to give you guys a real life experience, if you code a patient that has had an income of $500,000, it's actually interesting enough the same code that you would use for somebody that's a $10,000 income patient. So as you're gaining insights into patient populations, understanding these nuances is incredibly important to understanding social need operations. And as I'm sure everybody here in the room is aware, and just like my panelists as I identified here, we need to have a need-based organization that focuses on where the resources that we have available can be driven towards care in the most appropriate way. And we all know that there's not enough people to go to rural Iowa to work with, dual eligible and dual eligible patient populations for both Medicare and Medicaid. So how do you prioritize care when you don't have enough clinical people in the field at the most amount of time? And dealing with social determinants is a great way to actually quantify those patient populations. But when you're dealing with an ever-moving coding guideline of how you define those patients, it's always going to be complicated. So if we understand that that's a challenge in data, and if we understand that the people that are organizing data have to deal with that challenge, we can figure out solutions that are not only empathetic to the patient population that you're dealing with, but also just being cognizant that that's a systemic problem that's affecting insights into these patient populations as a whole. And as long as we're understanding that that's a problem, that's a first step in trying to find a solution. And so when you think about then trying to find a solution, if we can then find patients more appropriately in the populations, if we can understand them over time, if we can track them with appropriate patient outcomes over time, with empathy, with understanding, with social workforce that understands the race, ethnicity, the language barriers that are and the societal barriers that are core part and parcel to the care of patient populations. That's the first efforts and steps to take that next step and actually truly trying to have change in social and healthcare inequity in the area. Now, as you get into specialty care, like let's say oncology or behavioral health, those are all things that are also very similarly very difficult to understand in patient populations over time. It's interesting, many of the large health systems and maybe large payers that are out there that we are working with as an organization have these data challenges. They have 10, 15 data warehouses that might have 50,000 definitions of a bipolar patient within their patient population. So if you have different definitions of that data set, how are you able to then focus your care efforts onto those patient populations when you don't have the appropriate clean data to run that information behind the scenes? You can throw AI and ML algorithms at any kind of data problem, but if it's hovering around data that is already problematic to focus on an inequitable patient population, you're always going to have challenges in closing that gaps. And that's when you look at Pew Research, when you look at all these different research organizations that have been focusing on the challenge of these problems, you notice that these are highly unfocused patient populations, and it's a systemic problem that's happening out there. So as a solution, one of the operations that I would highly, highly recommend for any organizations is know that your data is dirty. And if you can know that your data is dirty and you have clinical oversight into that information, you can actually truly affect change in how you're understanding those patient populations. And that's user persona and industry-wide. That is, everybody has this kind of problem, right? If you're dealing with clinical data at the point of care, that's different than a payer or a plan or an insurance agent might be dealing with on claims data behind the scenes, right? Everybody knows, who's a clinician in the room here too, that an ICD-10 code does not mean exactly the same as a SNOMED code, does not exactly mean the same as a LUNC code, does not exactly mean the same as a CPT code. And those are always moving targets in understanding those patients. And understanding that that's a problem in the industry is something that we have to get around. And that's the first step, right? The second step is then, how do we then prioritize our care with the appropriate people that are cognizant of these challenges and are empathic to the social requirements of those patients to then be brought to the team in an effective way and in an efficient way too, especially in a realm where we don't have as much resources as we did a couple of years ago. And that's a challenge that organizations need to handle, but prioritizing those patients with better data is an easy way to get around that. So that'd be my second solution. And really the third solution, as you think about understanding the pharmacology side of the equation, understanding research operations that help with clinical trials, focusing on patient populations based upon these social determinants will help in understanding much more robust research operation for pharmacology and pharma research too. And you're focusing clinical trials not just on generic patients, but on specific patient populations and what those outcomes need to track as well too. And that gains trust. And I think that's what's lost in this whole ecosystem too, is that trust. And as long as we prove that trust to our constituents, then that'll be a very good and operationally efficient process to move forward with.
So as you were hearing all this, I want to kind of think through what's going to happen in the future. That's when technology comes up and starts. So I want to go through the balance. There was architecture. So where it is.
Yeah, so I find it interesting. I'm a clinician by training, and to hear the different aspects of the field where sometimes I get stuck in just treating that patient for mental health disorders, but not kind of looking at the bigger picture of coding and billing and data. And in particular with, say, if we focus on first responders, like coding them or giving them a diagnosis is enough for them not to want to even get treatment. Because if they get diagnosed with bipolar or PTSD, they may fear losing their jobs and their careers and their ability to do their jobs. And I think that might be similar to other professions where there's a fear of having that data permanent in their medical health record. So on one hand, they want to get the help, but then what are the repercussions if they do get the help? And then how can we show also how well our clients do perform, how well they get better, improve their lives after treatment, and being able to collect the data to show that there's efficacy in the treatment. So there's a lot of challenges, I think, in just having health equity, and I think it just comes down to education, but also working across different industries and fields, in particular government. For example, in Florida, there was a problem that, a lot of the first responders weren't getting help for their PTSD. And Florida actually enacted a law that they assume that all first responders have PTSD. So you don't even have to be diagnosed or have to have any type of proof that you have been suffering with a mental health disorder. And which means on the flip side that they're able to apply for workman's comp as having PTSD as a moral injury and being able to get treatment for that, but also not have to lose their jobs and eventually get back to working. So I think working across industries, politically, education, and prevention as best we can to reduce the stigma of mental health disorders.
Thank you.
Okay. So there's a lot I think that I want to cover here, but when we think about the mental health care system generally, we've adopted systems and structures in our society that create oppressed and marginalized identities. And then those people with oppressed and marginalized identities have the highest rates of depression, suicide, PTSD, substance use, all of these mental illnesses. And what happens is these populations also have the least access to care. So it's the inverse law of care, where the people with like the highest acuity have the lowest access. And that's just across the mental health field. And other things that contribute to health inequity in the mental health field include things like bias and discrimination, racism, lack of education, lack of trust in the system, lots of components. And so when you look at psychedelic-assisted therapy specifically, all of these concerns can just become magnified that we're already seeing within the mental health care system. So there's estimates that like $300 billion every year are lost from productivity from untreated mental illness. And not that I'm as concerned with like productivity numbers because I'm a clinician, but even working in ketamine-assisted therapy, what I'm seeing is that many of my clients, by the time they come to a ketamine infusion clinic, where treatment basically baseline is going to run $4,500, not including any other medications, psychiatry, therapy that these clients are doing, many of them are unemployed because they're so mentally ill that they can't function, or they're underemployed, or they're on like FMLA and like leave from their jobs because they're not functioning. And in 2020, there was a study that came out that indicated that the biggest barrier to mental health care that year was the cost of mental health care. So we've got all of these factors kind of contributing to this giant mess that we're then potentially replicating in the psychedelic therapy field because, you know, when MDMA becomes legal, that treatment may cost $20,000, $30,000 to access. Those are the estimates that are Australia is coming out with, where they just legalized MDMA and psilocybin for mental health treatment. So one of the things that I'm doing is I'm kind of cobbling together my own system of trying to address some of these needs, which include offering scholarships and sliding scale to clients who are low income, offering group formats. I run group ketamine-assisted therapy treatment, so reducing the cost that way, using a variety of level of skilled clinicians to reduce costs of what clinicians earn. Unfortunately, like graduate students don't get paid, but if you have a graduate student on your therapy team who's helping facilitate, that can reduce costs while increasing access to care. Partnering with nonprofits who offer scholarships and funding, working with companies that provide payment plans for clients. So trying to put all of these little pieces together, because the system itself, we're not in a good spot yet. But there's some larger systemic things I think that can be done. So there's groups that are starting to come together, like the Psychedelic Health Equity Initiative, who are looking at research and trying to address some of these concerns. There's a model, a research-backed model of healthcare called EQUIP, which looks at kind of these organizational and system level changes rather than like working on the individual clinician level. And so if we are practicing from these research-backed models, if we're contributing, like PHEI, the Psychedelic Health Equity Initiative, they're looking for philanthropy. That's part of the basis of their model of funding. MAPS MDMA training offers scholarships to clinicians. So we kind of have to approach this problem from a lot of different angles, I think, to address the issue. So, you know, reducing stigma by educating patients, increasing trust by having clinicians that actually look like the people who they're going to be receiving treatment from, improving research trials, because most psychedelic therapy research is being done on white people. Lots of different ways that we can address this. So I think the more creative we can get, the more different groups can come together. the more effective we're going to be. Because even like with health insurance, if health insurance covers this treatment, we have a lot of and underinsured people in this country. So I think it's going to take a lot. So hopefully there's some people in the audience today where this is planting a seed for you. If you're in the health insurance industry, if you are a clinician, if you have access to resources and capital and you can invest in some of these projects and programs and treatments, we kind of need everybody on board.
Thank you. We're going to have plenty of time for questions. I mean, if you like perspective as an outsider, can you hear me? So, I want to make the questions worth it. So, and I introduced this. I saw the same signs I was seeing in others. But one side, you have greed and fear. The greed for increasing your profitability by certain segments. On the other side is the fear of being older, getting incarcerated into something for that life, being disabled, needing a walker, needing help from somebody else to live. So this greed and fear is what has me as an outsider from Silicon Valley science. So, based on my own personal experience, my question was, how do I solve these fears? I learned during COVID, my fear of being injured, dying lonely, could be mitigated if I understand what's going on with the body. What is the weakest link in my chain? What exactly do I have to do to strengthen this weakest chain? So this is where the company has started, MediKarma. MediKarma came from the concept of engaging patients so that we help them every day in a very simple way. 3 things you can do to improve them. So, how do we do this? We recognize most of us, if you ask me to go look at Instagram, I'm not sure you do it. But if you could look at Instagram, I can take you. That's like lessons we learn from it. If you can come up with a very simple app that intrigues you, that engages you, there's something in there that kind of keeps you glued, that we will have a chance. So we basically decided, how do you play this patient psychology? First thing we did, as you and I are talking, I can create an avatar that you can actually see. It's many views. Within 25 seconds, they go get all your name or name with your consent or your doctor's consent. I bring this data, put around the body the status of your organ, like a traffic light, green, orange, and red. How do I do this? I basically compute using algorithms already available to compute what are the chances of you getting a heart attack in the next 5 years. What are the chances of you getting kidney issues increasing in the next 5 years? I use algorithms like Dr. Pankey, who's a well-known clinician. First phase, show you where you are, show you what is the weakest link in your chain, show you what kind of status you're in that you need to pay attention. Next, I combine your current status with how you behave. How are you eating? How is your workout? What are you stressing about? And what is your mood? These inputs are configured through a variety of devices. They're already there. Apple Watch, Honor, Libra, Telecom, regular sleeping orders. The inputs from the smart devices, the inputs from the RPM devices, and my last panel is somebody introduced you. She'll be your friend and she'll be asking you every morning, how did you sleep? What's in your mind? So she can think of some of this stuff. How many drinks do you have? These 4 subjective inputs are taken in the computed score, very small with Microsoft. We did this so that every morning you want to give your game. The score is 620. Why did it go up? Because you worked out, you ate well, you slept well. Why did it go down? There's 3 glass of wine here. Up, down. You present the score, and Jill pops up and tells you 3 things you can do to take your score from 620 to 630. So we consider all this very simple concept. What do I do? The industry now is action. And we put this to a humanoid interface called Jill AI. Jill has access to your EMR. Jill has access to all your diagnostic information. Jill can actually tell you, if you ask her a question, what is diabetes, she can answer. If you ask her what is my diabetes, she can answer. What are my comorbidities? What am I dealing with this one? She can answer. So with that, I will show you the demo. Our 6 panels Jill AI that is being deployed, that is being clinical trial right now with some of the providers and this way there. I talked about creativity. The reason some of the providers are really big budgets is their expense. They care about cost of care reduction. How do you achieve cost of care? You achieve cost of care by getting your patient population healthy. How do you get your patient population prevented? So if these folks get started with what's going on in the body, even when they are 35, if they can help them visualize what's going on in the body, they are if you're 55 when you're feeling good, walking around, and they can show you what can happen in the body. At 55 or something like my doctor talked to me. I had like aha moment. Oops, and then we get in trouble. If we can educate that, that's what parents are looking to get help. That's what providers who are now going from fee-based service to value-based care are looking for. This is the missing piece. Patient engagement, preventive care. Two, motivating patients. So with that, let me show you the model. Hey Jill, how are you doing today?
Hi, welcome back. It looks like you're making great progress with your health and wellness goals. Your health score went up by plus 25 points over the last week. Keep up the good work. Do you want to learn more?
Yes.
Your improvement in score is mainly driven by blood pressure reading, which decreased to 138 to 130. Your goal is to get to 128. Secondly, increase GFR score from 60 to 75. I got this information from your recent lab results. Your goal is to get to over 90. You are moving in the right direction. Keep up the good work.
What is GFR?
The glomerular filtration rate GFR is the rate at which blood is filtered by the kidneys. It is a measure of how well the kidneys are functioning and is used to diagnose and monitor kidney disease.
So, what do I do now?
Your latest recommendation is as follows. Your blood pressure value has recently increased. You had hypertension. It's imperative to implement lifestyle changes to lower your risk of hypertension. Please discuss with your medical provider to help you ensure optimal control of your blood pressure, including lifestyle habits.
I can go on. So I have one more person in my life telling me what to do this. But the point is, when people talk about technology, AI has first reaction is university jobs. You should not care what the technology is. You should care about what is in front of you. What purpose it serves. How do you use it? When you take your phone every day, you don't think of the processors and operating systems behind it. You're very eager to click CNN and look at the news. Or something else, hopefully MediKarma also. But that is my message. While we talk about technology, AI, and all this stuff, let's listen to these folks, figure out what the problems are. Let's figure out how to solve the problem. How can I make Jill available to everybody? How do I solve the problem of Yellowstone not having enough doctors? Have retail people. How do I put a Jill for Alabama or Mississippi, where the population is in their 20s, and have weight problems? Can I put a whole big Jill? Can I put a different Jill that is different ethnicity with different ways. Health equity is not just about access to healthcare. It's not about quality of healthcare. It's also depending on health. So what we're thinking is, if we can make Jim to offer your clinician, then it's right. So the Jim is available for you to talk to them. Then you are increasing the supply of care. And if you focus on preventive care and patient engagement, you're increasing the demand of care. That's exactly what we're doing. Do you have any questions for each other? Should we turn on to the audience? So I'm going back to you folks. Do you have any questions? Ask us. You guys come to your microphone. I have all these ones here. Organizers, do you have a microphone for people?
Looks like we have a question in the back.
Okay, go ahead.
In the back.
In the back.
I'm sorry.
Yeah. Hi.
Are you using the impact of the supervisor and the post-study for
Right. Mm-hmm. Yeah, so I've had a lot of clients actually drive from fairly far distances to come access this treatment. Sometimes takes over an hour for them to get to the clinic and then over an hour to get home. I've offered to some clients actually like, hey, I will come to your home and do a ketamine session from your home. I have experience in the nonprofit world where I had to go into people's homes to provide community mental health. So that's something that I may be comfortable in a way that other clinicians are not. There are other models of ketamine treatment that provide at-home services with varying degrees of client monitoring. And so those types of models, I think if you're a clinician, are really dependent on your level of comfort with like safety and risk issues. We know that ketamine medically is an extraordinarily safe medication. But what can happen is that psychologically it might not be safe for people to enter into non-ordinary states of consciousness, enter into this terrain of the unconscious mind, and uncover difficult or painful things that need to come out and be healed. So if people are going to be working with ketamine at home, I just do a lot of preparation work, a lot of harm reduction, and try to educate them on best practices, and ideally either having someone in your home who can kind of tend to and keep you safe, or there are some companies that do kind of this remote modeling option. I just haven't done a lot of that yet myself. But the access to actually getting to the treatment is a huge concern for rural communities, people with disabilities, low income, things like that. Mm-hmm.
And you actually bring up a really good question too on VA's access to care within the patient population that's our veterans. There's more recently, I think, a cognizant connection that the VA has made to say this is a problem. Access to care within the VA is a problem, and building a brick and mortar building in rural Montana to meet a large patient population might not be as financially viable as maybe partnering with a local health system near me to then spin up a VA location within the brick and mortar building of the healthcare system that might be local. I think we're seeing some of that happen today where I think it's a UPMC or Jefferson Health recently partnered with the VA location to actually build and partner and put a VA hospital access site within the health system itself. So public and private partnership to gain access and more viability to those veterans is, I think, starting to become a use case that's popping up. But I think the first step in that was, I think you're right, it's identifying that there was a problem in access and organizations partnering to accelerate its adoption in direct care.
Yes, sir. Yes. I have, first of all, a lot of things about what I'm seeing here, and long this, nobody's mentioned the effect of the environment. And as we came all, we got the root cause as we static population, as we move over air quality related to the allergens kids were exposed to in medical markets. Until we go back to that, and one of the things about is data response, but not correctly said, is that data sits in the silo and it doesn't come together to how to do that. Get to what are the root causes that are driving that sort of effect. So the purpose of the commercialization now is to pull all that data together from the various silos and use the work with the data group. Your biggest challenge is how to get the data from all those different places and share with the conflict and then distill it down so that somebody looks at it and find that something. But they've got a sense of right with that kind of text. There's a creative vulnerability of it. So I can tell you this is going to be less now to sense of what their needs are mental health services based on health. That's the kind of data we need to provide. And then finally, we need to get out of the large institution of large technology and down to the local level. One of the things I want to talk about before I retire is stop building about others. Go back to store, meet them where they're comfortable. Because that's how you generate the trust where they're comfortable. And then we keep working on techniques. So one of the things we're exploring right now is use products like those that get stumblers to one thing to fix their apartments. Along with that, we have to give them assistance. We need to hire them on the house, figure out all out, and they have to invest in our people because they contribute not the water contributes 9% to our greenhouse gas problem. If we eliminate all that people like it, we go down 9% or 9%. Probably we put a small legacy people out there. So we have a lot of so that's just great points. Rick, any comment on that?
Yeah, I think that, everyone here would agree that it's a lot of the things you touched on are really important. I would caution though that, I've seen a lot of sort of these, large meta-analyses where, people get excited and they take data from all different places and they try to bring it together and make sense of it. But in sometimes they're comparing apples to oranges. And it,
right.
Yeah. So, that's part of the caution, making sure that the data that you have, is going to help you really better understand the challenge that confronts you. And too often people get excited about the data and they lose sight of the fact of what this data is and what it's supposed to do. So anyway, I think that we all probably would agree that those are some of the right directions, and certainly looking at social determinants of health and trying to understand how does a person's environment impact their health is critical. I also would agree that the idea about building some of the mega clinics. Again, if it's going to be able to solve health problems for people in the area, that's great. But when we looked at adherence issues and we asked people, what are the biggest challenges to you adhering to your medical treatment regime? There were roughly 20% of people who said access to a pharmacy near my home or work, which was frankly surprising because you can look at the pharmacy saturation data Like the average is there's a pharmacy within like 2 miles of every American. So it's like, again, that's an average, but just because there's a pharmacy near you, does that mean you're getting the medication in your hands? So we don't want to try to make assumptions based on some of that data.
I can jump on this point. Because the next thing, we talked about wild evolution. One of the things we did in some of the health systems is how to use this score that we create. You don't have to wild evolution. You figure out what you're trying to solve. In this particular case, this may have brought 65 million de-identification us. They said, please tell us what are the top 3 diseases that's taking most of our budget? And what are the top percentage of people that's eating 95% of the cost? So without wild evolution, we just looked at that and we were able to come back and prove health score is correlating to your cost by 90.6%. 65 million. So outcome of that is going to be understanding the population of the report, where the health score is going up and down. What do you have to do to help that cost? Go ahead.
First, I just want to say thank you for the passion, enthusiasm, creating all this analysis. Thank you. I have a question for you later. But for the minimum Andrei and
My name is Rick Johnson, the mystery panelist. Not on
So yeah, there was a lot mentioned, getting to that holy grail of that advantage. We can believe that's obviously removing a lot of the biases. So I'm speaking my language. And I just thought the environment was great. Just an obvious question, which is what correlates to genetics. So do you see, especially with the funding costs, particularly sequencing data, do you see a role for human genetic data in the body mix? If so, have you envisioned that being used representatively or technically?
Yeah, I think those last words that you used are the key. The question essentially was using genetic data to sort of be added to the mix of the data that we have and use that to improve people's health, essentially. Is that fair to say? Okay. So that was the question. And he had sort of ended his question with saying, it has to, ethically, thoughtfully. And I said, those are some of the key phrases, right? There's can and should. Can we do something and should we do something? And we shouldn't evolve to the should until we figured out the should piece. So do I think it's going to get there? Yeah, I do, because I think it's an important lever that can be pulled. I think we're a fair distance away from being able to pull that in the majority of cases because we haven't figured out some of the moral questions about how that can be applied, and to make sure there are real safeguards in place where if somebody has genetic markers for certain conditions or certain, there's one which is the serial killer genetic sequence. Okay, somebody who is a law-abiding citizen happens to have that. What happens when their employer finds that out? How is that information used? So there's just a lot of care that's got to be used before that gets brought forward. However, all that being said, I think it's a tremendous area. And, there are pharmaceutical companies are already looking at that and trying to understand, genetic treatments and certainly looking for genetic markers to be able to help identify people who have no symptoms of breast cancer, but have all the markers for breast cancer. And I'm sure in terms of mental illness, and I would defer to my panelists on this, but my understanding is that there's very strong markers in that as well that can be identified early so that people can get help they need and treatment that they need before a problem surfaces.
Yeah, I'd love to kind of add to that, just about the psychedelic field. There are companies that are looking at genes and which folks respond to which psychedelic medications based on their genetics. So there's some interest.
One more question.
And I would say too, really quickly, as you think about its application of using genes into, like, let's say, benchmarking social determinant risk understanding, I think the first thing to understand with full genome sequencing is the first one is your baseline, right? Your first test that you take is your baseline. As different social determinant factors, or whether or not you live close to a coal burning fire plant, or whether or not the nuclear power plant's wastewater is affecting your drinking protocols, that can be a impact to them changing your genomic sequencing in your next full genome operation to figure out what has moved in your somatic or genomic representation of your full genome.
But I'm very curious about how AI can impact healthcare and health. It's a unique situation, right? The family, the village world has increased. One is the knowledge how do you think AI will impact that?
Like the answer, but I'll put it this way: we are working with a group that actually both PCE is Supervisor of population. How we are approaching this is we are creating a wellness tool. Wellness tool has a library of all questions you can ask and a library of answers, qualifying questions, qualifying answers. So we are actually implementing Jill as a wellness tool to supplement what this great guy is very well known. Butch, the barber science, nice dog. They're basically replicating him and bringing knowledge. That's one way of doing it. I'm sure the panelists will have other possibilities. We've been out of time though. We're going to be here on the side. If you have any other questions, feel free to stop by. All the panelists are available. So I will comply. Thank you for your time.